Hi, everybody. Thanks for coming. We're going to give the stragglers a few more minutes to get signed on and get seated, grab their popcorn, and then we'll go ahead and get this thing started. All right, we'll give people just about another minute, and then we'll go ahead and get this thing started. We do have a chat up and running. If you have questions, feel free to toss them in the chat. As I'm going through the presentation and I have some space to breathe, I will be watching the chat for questions. And of course, at the end, I will be hanging out to see if I can't go through and answer anything that people desperately want to. All right, I think we'll just go ahead and get started. Again, I want to thank everybody for taking some time out of their day to spend an hour or so with us to Here we talk about some new technology coming forth from OSER and Touch Solutions. We'll go ahead and get started. This is Connecting Advanced Surgical Techniques to Technology. So we can't go through any of these presentations without acknowledging some basic background information. We've seen this slide in various shapes and forms as throughout the months and years have gone by, but roughly 1.7 million individuals with limb loss throughout the US. Of those, about 41,000 are major. As a reminder, we look at the definition of major and minor. Minor is anything distal to the wrist. This does not define the impact that it has on the patient's life. Major is everything from the wrist on up. There are roughly 20,000 cases of upper limb loss or deficiency each year, and of those, 90% occur at the wrist or distal, and those are what we would call the minor injuries. What's interesting, this is mirrored in both the workplace and in military populations, so it's not just within the civilian world that we see this. When we look at how these injuries are defined at the impairment of a person, if we look at the AMA guidelines, they determine 4 fingers lost at the metacarpal level as a 32% impairment of the whole person. 4 fingers and a thumb brings that up to a 54% impairment. As a reference, a short transradial is about a 57% impairment of that whole person. So just losing that thumb and those fingers impact someone on a really large and significant level. So we want to make sure we have some tools that we can use to help those people get back to what they want to do. And if we look at a survey of surgeons on how partial hands, prostheses, and surgeries are perceived, some of the things that are interesting that come out from this data is that gross motor function and pain reduction are, of course, the primary importance. Now, when we look at aesthetics, this is something we see anecdotally. This is not always the big driver in how a surgery is performed. So this results as what we sometimes call a little more gnarly presentation and how the hand looks. Also of interesting is how the perceived return to function is looked at. And if we look at how surgeons looked at what they thought would give the best return to function, of course, you look at a hand transplant is right up there, toe to hand transfer replantation. Body-powered prostheses are perceived to give the least return to function, whereas electronic digits were looked at almost on par with doing something like a toe-to-hand transfer or replantation of the digit themselves. And this is just how the surgeons perceive. So there is a bit more of a perceived benefit of using these electronic devices over body-powered or even the passive cosmetic type devices. For an overview for eye digits, the classic eye digits, they are an articulating digit with the ability to individually stall. There's a motor in every digit. There's a processor watching how much power is being supplied to each digit. Because of this combination, whenever a digit wraps around something, it sees that stall. There's a big increase in power draw. The digit will stall out and hold that position. That's what we call that compliant grip. The device is going to take the shape of whatever you put in there. The user doesn't have to do anything different. They fire that close signal, the digits wrap around the object, and you get a secure and stable grasp. There is a manually rotatable thumb. If a user is in need of a thumb, there's a device that can be added in. And there are a whole bunch of different automated grips and grasps and different options that users can have to help them accomplish whatever task that they're trying to achieve. Eye digits are appropriate for various partial hand level. Ideally, we would like the amputation to be just proximal to the MCP joint. That gives us enough room to mount the hardware, have the silicone in place, have the knuckle block. And if there are intact digits, have the joint center of the digit align with the anatomic joint center. Now, of course, as we saw before, this doesn't always happen. So what happens is the more distal that amputation is, the more compromised we have to do things in terms of alignments and even sometimes function. So the classic, we have that disarticulation at the joint. That just means that those joint centers are pushed a little bit farther distal on the digit, which if they have something like an attacked thumb, that allows us to still get a tip to tip. But as we go more distal, we lose that ability and sometimes have to compromise some of those different grasp patterns. We do go by the AMA guidelines for impairment to determine whether or not someone is a candidate for digits. The AMA guidelines look at what each each finger contributes to the overall function of the hand. So ring and little each count for 10% of the overall function of the hand. The index and middle are each about 20% of the hand function, and the thumb accounts for about 40%, which kind of makes sense. Our thumb allows us to have our tip, our gross grasp, and our lateral grip. Little finger doesn't do as much. So when we look at these, if someone is looking for a device and they're missing just the little finger, even if it is just proximal to that MCP, probably not a good candidate for an iDigits device, because the return in function that they're going to get might not be worth the cost in terms of training, device, loss of sensation, all the additional hardware that's needed. These devices are intended for light to moderate use. If someone's going to be doing something like their ADL task, they'll work just fine. Hanging a picture on a wall is great. We have people shoveling snow, that's fine. But if they're going to do something like some roofing kind of work or heavy construction, there are other devices that are more appropriate for that. The devices are very field serviceable. All the components can be replaced in the field, everything from the wristband to the batteries to base plates. With a little bit of practice, you can pretty much strip one of these down to its base components in a little under 45 minutes or so. We, of course, if something needs to be replaced, we are more than happy to send you out a part. If you do want to send the device to us, I'm more than happy to go ahead and do it for you. As I mentioned, they are customizable. You can do 1 to 5 digits. The only real single digit that we found to have a whole lot of success with is the thumb, again, because it contributes to about that 40% of hand function. By replacing that thumb, you get that hip back, you get that lateral grip, and you still can have some of that gross grasp. You do have the option to change the different sizes and alignments. You can change your base plates. You can do individual knuckle blocks, should you desire. If you don't recommend it, the mounting plate still works pretty well. We do cheat a little bit with our wristband. That wristband allows us to have some range of motion at the wrist. But the other thing it does is it moves the weight of the processor in the wristband more proximal. So it's not hanging off the end of the residual limb. So there's less perceived weight on behalf of the patient. Traditionally, these devices, like a full 5-digit system, usually ends up just about over a pound. So they don't weigh much, but anything we do to knock off a little bit is something that we're going to take a look at. Classically, what we're looking at for our myocytes, if you were doing a 2-site system, the hypothenar compartment is a good place for us to start looking for control of the device, either abduction or flexion of that little finger. The thenar compartment is another good position to look, whether or not it's the flexor, opponents, or adductor. If someone, of course, does have an intact thumb, that eliminates that as an option. Some people can still isolate the abduction of that little finger from flexion, so sometimes we can still use that as a control site. But last but not least, the intrinsic to the hands, we can use those dorsal interossei. You, of course, still have the option to go more proximal. You can get sometimes some of the extensor carpi or flexor carpi, or even the classic flexor extensor wad to operate these devices, but that comes at a cost. If you're using those myocytes that are extrinsic, you sometimes you do have to do something to eliminate that wrist motion or block it in order to keep control of the device. As an example, this is one of the more popular thumb-only kind of devices. Is something that we see pretty frequently. The amputation is a little bit more distal. We can see on the thumb, there's still a little bit of the thumb remaining on the hand. In this particular case, the range of motion and strength was still good in the remaining fingers. We do end up mounting the thumb in the palm. Sometimes it can look a little bit odd because it's kind of pushing that thumb out in space, but we have to work around the intact anatomy. And what that does is that oftentimes you end up what we call that classic thumb bump, that little lump in the anatomy on the socket where that intact thumb is left and remained inside the prosthesis. But with that thumb mounted, we can get that tip, we can get that lateral, and we can still restore all that gross grasp. And it's kind of impressive how much someone still use that key or lateral grip in their daily tasks. As a classic example of a 4-digit prosthesis, in this case, the amputation was just proximal to the MCP for that index and a little bit more proximal on the rest of the fingers. Thumb was intact, still had good range of motion from the injury. And it's something to note, the mechanism of injury can have not surprisingly, a big impact on what's left. The difference between a cutting injury for the fingers versus a crush. With that crushing injury, they can be a lot more, can come damage to the hand, which can limit some range of motion of that thumb. Of course, as you go more proximal with amputation coming up to the thumb, you can lose some of that range as well. In this case, still had good strength and range of that thumb and good intrinsic sights and control. So we were able to mount those digits in an almost anatomic position. As someone loses that range of motion at the thumb, you do tend to do more things like supinate, sometimes a little ulnar deviation in order to still get that tip and lateral grip to line up where you want them to be. With the classic 5-digit presentation, this was a left 5-finger amputation. It was a traumatic. The skin is well healed. In this case, the wrist was spared, which was nice. And this is something this particular individual, for his control sites, ended up using the flexor digit mini as well as the thumb, which is something we don't tend to recommend, but he was able to do it. So when you're doing your myo testing, there isn't one way to do it. Get as many site options as you can, and as you're going through that fitting process, identify the ones that work, the sites that the patient can successfully isolate as well. I mentioned sometimes it can be hard for people to isolate the abductor, digit minimi, and the flexor. If they can do it and can do it consistently, use that site. It's what's there, it's available. But in this case, we were able to do a 5-digit prosthesis, restore our grasp patterns, keep the silicone short to allow for that wrist motion, and then still have that wristband so they can still flex and extend. And we can't have a presentation without mentioning some outcomes-based research. Something that Touch Bionics and now Ozer had been working on for quite some time. In this particular case, this study was published, I think, back in 2014. And the goal was to identify important but problematic tasks in individuals with partial hand amputation. And we did do this study with local folks here at OSU. Typically, we do want to create goals for use with prostheses. We want these goals to be tasks that are important to the patient themselves, not something that we think is important for them. Part of that is, as we all know, the rejection rate for these devices are pretty high. Anything that we can do to increase the likelihood of someone not putting it up on a shelf is something that we want to look at. So if their goals are important to the user, well, we want to make sure we can do that. For this particular study, we used the Flynn Performance Screening Tool, which has a battery of different tasks. And the clients go through and identify the 5 tasks that, again, difficult and important to them. For the study, we had 15 participants, 11 male and 4 female. And what we found was that of those, people tended to select 18 tasks in general. Only 37 of the tasks were not selected by at least one person. The top tasks identified are pretty reasonable: cutting meat, trimming nails, and peeling vegetables. So these are the things that, are pretty, what we would expect in terms of being able to maintain independence, right? Or being able to prepare food, take care of themselves, and do their dressing kind of tasks. So moving on for those, we also wanted to look at whether we could determine if there even was a functional benefit of using an externally powered prosthesis for a partial hand scenario. This one, I believe, is published in 2018. We used 2 standardized measures. We used the patient-specific functional scale as well as the SHAP. We recruited, I think we had 6 4-digit and 9 5-digit. And if I read the slide, it says that very same thing. So that's good. So we recruited individuals with both a 4-digit and a 5-digit loss to perform these 2 tests. So the patient-specific functional scale measured goals that were not only important but difficult for a user to achieve. Change of 2, it was clinically significant. And in particular, we looked at the 5 most common goals, the ones we had noticed in the previous study. When using the prostheses in a 4-digit case, the average increase was 6.75, and with a 5-digit was 5.3. On all in total, the average increase in priority tasks was about 5.6. So these devices in this scenario did have a measurable benefit. When looking at the SHAP, there was a significant improvement in the scores for all users. In 4-digit systems, the average SHAP score, I think, went up by about 19 points. And in the 5-digit systems, it went up about 40 points. So again, not only a clinically significant, but a statistically significant, for upper limb, pretty decent sample size. it was so good, we decided to partner once again with OSU to look at using these devices again, but we want to take it up to the next level. So in this case, we wanted to look at how users were using the device and how they were compensating. Because one of the things we found with a lot of these outcome measures, while they're using the device, none of these measures look at the amount of lateral trunk bending or internal rotation at the shoulder that a user is doing. So we still use the SHAP, but we also looked at the upper body kinematics in a food preparation task. And then going back to what those goals were, this is an important task, so we figured why not use it? We were able to recruit 6 individuals with partial limb loss, 3 4-digit cases, and 3 5-digit cases. So we know what the SHAP measures. We did see a significant improvement in the SHAP scores in the 5-digit case, not in the 4-digit case. And I think part of that was due to the difference in numbers in the previous study. But one of the things we did find is that the prostheses got a user back to what would be more normal kinematics as they were accomplishing the task. So unlike in lower limb where there's that gait pattern that is fairly distinctive, there isn't one motion. So we actually had to go through and we had to do the data collection for subjects to determine how they would accomplish the task and then compare that to users with their prosthesis and without. And what that looked like is if we look at the first task, I turn my pen off. There we go. If that video, you can get that video playing. And this particular task, you can see the user, there's a cutting meat. He was able to pick up his knife and fork, and you can already see that shoulder hiking, that lateral trunk bending, a little bit of internal rotation as they twist that arm. Try to just cut a piece of meat to get it ready for a sandwich. When we compare to the user on the right side, some helpful labels. You can see what the study revealed, not just that it looks a little bit more comfortable, a little bit more casual, there is less accommodation occurring. So some other case examples that we have, as we mentioned before, these presentations are not always ideal. Part of this issue is because surgeons are unfamiliar with the prosthetic options. And even some, as prosthetists, as the field changes, we're not always kept abreast of all the different changes that are going on about, which is why we attend these cool seminars. It also stresses the importance of this multiple disciplinary team. We've been banging on this gong for, I don't know, in the field for the past 40 years or so, but it turns out that whole team approach actually is important and can get some solid benefits. The other challenge that we deal with partial hand presentation is that there is a huge variability in how that presents. If you've seen one case, you've seen one case, right? So there is a lot going on with each individual. There's always compromises that you have to work with. We talked about gross motor function and pain reduction are always primary, and the aesthetics are not a primary concern. So sometimes we end up with that last little bit of an index sticking out. There may be some bone, there may be some drift of a digit. These are all things that as prosthetists we have to work around in order to get a good functioning device. The other thing that allows us to do is we do end up having to mix and match our different components. We use the different parts and pieces from different devices in order to get the best outcome that we can. And this particular example, this case was a gunshot wound. This individual had put their shotgun down on the ground. It started to tip over. They reached over to grab it, and unfortunately their hands crossed over the opening of the shotgun, resulting in the amputation that we see on the screen. So some of the challenges that we got right on the get-go is on the left side. That index has some pretty heavy ulnar drift. You can see it kind of angling off to the ulnar side just in that device itself. So that's going to have a huge impact on how we align our digits, because we want our digits to track to line up with that thumb to go right where that index is sitting. Just to make it a little bit more exciting, the thumb actually had some limited range of motion into palmar abduction. So it was difficult for them to line up to get any sort of pinch tasks. You can see also on the right side, they ended up having a ray resection, as well as some other limited motion of that. of that right side thumb. So what we did is we ended up using a strap to try to pull that index on the left side up into a more neutral position. We have tried doing things like doing some silicone buttressing. We found that typically when you try to use a buttress, you end up using so much silicone, it ends up limiting where you can actually position your digits. So a lot of times you end up with some sort of strapping to try to pull that index or other remaining digit back into a more neutral position. This is, of course, if the joint and digit finger itself are flexible enough to allow you to do that. If you have a bony deformity, well, that's one more thing we're going to have to work around. We, of course, added some D-rings and loops and Velcro to help him be able to don and doff the device independently. The thumb had that lack of opposition, so we ended up building a palmar pad. I don't know if you can see the leather that's mounted up in the palm. There's some foam back behind there to help give that more shape. So when grabbing onto a cylindrical type object, it doesn't just kind of scooch out of its grasp. On the right-hand side, ended up doing a thumb CMC splint to help stabilize that joint, as well as a little abduction spacer to help keep his fingers apart. As he was an avid hunter, he was not ready to stop pursuing his hobbies. So in order to get that spacer, allowed him to still be able to support his firearm and pull the trigger on it. So in all, he was pretty successful. Another challenging case that we see with that amputation being a little more distal in conjunction with a partial amputation of the thumb. So the challenge is you have a longer base where you're trying to mount your digits, as well as a shorter thumb to try to align your grip and grasp with. Luckily, the range of motion and strength in this user were still good, so we had at least the ability to still have our wrist flexion and good strength in order to operate our device. What we end up doing is, you can see the challenge with those longer amputations, that the joint center of the digits are difficult to line up with the anatomic joint centers. So the longer we go, the more difficult it is to get everything lined up. You can do some things to lengthen the thumb as well. You can do silicone buildups. We found traditionally, if you're just doing a simple silicone buildup, the digits are actually strong enough to kind of rotate that right off the remnant thumb. So you got to make sure you've got a pretty sturdy almost addition to that thumb. There's all sorts of cool things you can do with silicone and 3D printing. So make sure when you're getting that on there that it is something that, one, the user is interested, and two, that the digits don't immediately overpower when using. Other challenging cases that we work with, on the top row, we've got an individual, those index and middle digits were actually stuck in that amount of flexion. So donning and doffing the device was a challenge. The solution for this was to cut that socket as low as we can go. And if it can't show up as well for you, you can see that frame is cut way down low, almost to where the thumb is mounted on the device itself. The silicone is left a little bit higher, still for good suspension, but that allowed them to actually get in and out of ice by kind of rotating their wrist and kind of hooking into the prosthesis itself. On the lower low, the big challenge again we have with him is he's got that ulnar drift going on to mount that, which impedes where we actually mount our digit. You can see we ended up with a strap in place. The other big challenge, that thumb was actually fused. He had a little bit of a flexion extension, no abduction whatsoever. So we had to get the whole hand basically through the space the size of a wrist. We ended up adding another strap over the base of the thumb that allowed the silicone to almost peel off like a clamshell, and allowed him to push his hand through and then ratchet that strap down to kind of lock back behind the thumb, and then that strap to pull the index, and allows us to mount the digits to still get some sort of gross grasp, as well as a modified type of tip pinch. But there are more hybrid solutions. And we said we will beg, borrow, and steal from anyone we can get components from. In this case, this is a combination of iDigits with a thumb driver and an MCP driver. As much as possible, I like when we're doing this to try to keep the plate separate. That allows the user to pick and choose how they're using their prosthesis. If they want to get down and dirty, they can still use the thumb driver and digits themselves. Or if they want to use it a whole system, they can. And this particular user still had that dual site control using the dorsal interossei, and they were able to use the abductor digiti. So still stick that finger like you're doing that shark shadow puppet and still control flexion extension of their MCP driver. They get a little bit more involved. In this particular case, we ended up having to mount the MCP drivers directly into the silicone, but we had our MCP drivers, we had a PIP driver, as well as an iDigits thumb. So we were able to align this to allow get our tip and lateral with the index and still get gross grasp with those remaining jizzits. Because of the presentation, we really only had that option for that single site control. We ended up using the thenar compartment, almost giving someone an infinitely positionable opposition post, as well as the ability to have that key or lateral grasp. So on to more good stuff. As surgical techniques improve, we have to make sure we keep pace with our hardware. Different surgical techniques for upper limb that we see more and more common, the targeted muscle reinnervation, the RPNI, as well as starfish. We'll talk a little bit about the effects this has on our phantom limb sensation and why that's important. And we'll also talk about the injury effect on our control options, not just our myocyte selection, but also our different control strategies. So TMR has, of course, been around for a hot minute. It was originally intended for control of a myoelectric prosthesis, to try to give user more sites for essential prosthetic function, hand, wrist, elbow, and shoulder. It was initially performed, of course, on that shoulder disarticulation. Transfemoral is ideal. We're seeing it more also as transradial, but also in lower limb as well. That nerve is transferred to a new site. It does new thing because it's a new control site as an option, but it also preserves that existing control site. This isn't a new theory. It's been around for quite some time. I think it was initially posed back in a journal in like 1917. So the idea has been around, but the techniques to actually do it are relatively recent. The other goal we have in improving control of that prosthesis is we have to improve that E and G signal quality. They do that through reducing the subcutaneous fat and kind of isolate the new myocyte with scar tissue. So now you've got this control site in a grafted situation that is isolated from the muscle itself. You can also, depending on where you choose your site, you can use bone almost as like a reflector. So if you're using something back on the scapula, it'll actually reflect that signal back towards the myoelectric sensor to improve that signal quality. Other surgical technique that we're seeing more often to give people more control of their device, the regenerative peripheral nerve interface coming from University of Michigan, help improve the signal specificity and also achieve long-term stability. If anyone was at the academy, I think they had a nice presentation of one of their long-term users of the surgery. But what they're basically doing is taking a free muscle graft and wrapping around a peripheral nerve. That gives them access to intrinsic hand muscles, but it also uses the patient's own musculature as almost like a bioamplifier. Currently, it is still using for an implanted electrode, but they are looking at doing surface-mounted EMG or even the possibility of using ultrasound, which is an idea for prosthetic control that was always kind of float around the reacher space, but never made it anything that's commercially viable. What they've found with these surgical techniques is that that phantom limb pain is, of course, difficult to treat, but both TMR and RPNI have been effective in treatment. So we're seeing this done surgery-wise, not for necessarily control of a prosthesis, but more for just the reduction in incidence in pain scores. And they have found in research that these are effective more often at the initial time of surgery rather than going in for revision. So we're seeing this more often done in the field. So it is something that is being just done, and we want to make sure that we can harness that control as well as we can. So for what we're looking for prosthetically, for a prosthetic partial hand circle goals. One, of course, we want to improve our prosthetic function. We want to provide more improved control options for that prosthesis, not just additional input options, but also more intuitive or natural kind of control strategy. We also want to make sure we get a cleaner signal and try to minimize that crosstalk or co-contract that you see. And fortunately, at the partial hand level, there is a surgery. It's called the Starfish procedure, which provides independent surface EMG signal for myoelectric prosthesis control. In this surgery, they take the interossei, they elevate them and shift them dorsally to the back of the hand. They take a piece of the volar plate and the flexor tendon sheath, and they use that to isolate the interossei. While in TMR, they use some scar tissue. They build up that scar tissue, isolate that signal. They're using pieces of the tendon sheath and the plate to actually isolate the signal itself. And now with that interossei shifted up, now you have muscle flexion controlling that digit flexion itself. So we did participate in a study, and without these people, this product would have never come to fruition. So we'll make sure to thank everyone who participated. We worked with Ortho Carolina Hand Center with Dr. Gaston Zloffer, as well as Hanger Clinic, in particular Brian Monroe and Amy Todd, in order to go through this study. The goal is we wanted to be able to independently operate digits using a 4-channel EMG controller, and then examine if there were any clinical benefits of using this discrete control following the Starfish surgical procedure. So we had 3 users with existing prostheses, and they had already had the Starfish procedure, and they had a battery of outcome measures that they looked at. There was an accuracy test, being able to flex the appropriate digit, a clothespin relocation test, as well as the SHAP, a cognitive burden, the patient-specific functional scale, and as well as the clinician interview. The hardware involved, it is a digital preamp. It is another piece of hardware that sits between the wristband and the electrode sites themselves. In this setup, we're using 2 electrode domes per signal site. We can have up to 4 different sites, so that's up to 8 domes incorporated into the interface, as well as a single dome for your reference or your earth. At the diagnosis phase, we should all be familiar. We want to make sure we get electrodes and fit as good as we possibly can, so we use that check socket to confirm the fit and our electrode placement. Using those skirts, the same ones we use in the traditional iDigit systems, as our template, we can mount our domes and our hardware in place. We're still using those diagnostic boards at that initial phase. Allows us to place these, make sure we get them in the optimal position, as well as the user can isolate those signals and control the digits themselves. When it's all said and done, it looks shockingly similar to a regular iDigit device. But just like us, when you open up and look on the inside, that's where it all counts. So its space is at even more at a premium. Before, we're working on where to put all these digits. Now we've got up to 4 sets of electrodes, as well as a preamp. We've got to shoehorn somewhere into the hand itself. We can alter the length of the wire. That is something that we would have to do at the time of service. It's not something that we want done in the field. It turns out that that digital preamp is particular to the amount of electrostatic shock it receives. So when we're mounting the device, we want to make sure there's room for that digital controller and all the hardware inside. So we use our skirts. We can add that inner frame to help control the amount of shifting of the electrodes themselves. But other than that, fabrication is about the same as we do with regular iDigits. As a review of our control strategies with traditional iDigit systems, we do have the dual site control and our single site. And if you are using the discrete controller, you will see another option show up in BioSim itself. It is the discrete control. What discrete control is basically is up to 4-channel control. You can have 2-channel. I don't know why you would have 1 channel, but you can, should you desire. It is voluntary control per channel with a lock, which means that the user fires the signal, the digit flexes. If they hold the signal, it will lock in position, and they unlock it with a quick signal again. And you can control up to 5 different digits, and the user, or in the process, will assign those digits to the channels as necessary. You can have any combination you want. It's up to you. You still have the option to utilize quick grips, but you do have to use the app to enter and exit through the BioSim software, because when we switch to that discrete control, we've only got that voluntary closing strategy now. We don't have the option for doing something like a hold open or a co-contract. So you still have the option for doing the quick grips, but you have to enter and exit with the app. BioSim is still your best troubleshooting option. When you connect to the system, one thing you may notice when you check the about, there's now an additional firmware and hardware version to make sure that everything is working as it should. If you do not see the discrete controller showing up, that is either something wrong with connection or with the hardware itself. So that's your first troubleshooting step that we would typically go through when using this system. When on your control strategy, now you've got your dual site first over, your single site options, and down at the bottom, now you have your discrete control option. On the right-hand side, there is a little clock that likes to hang out there. Sometimes it can be kind of hard to notice. But what that is that allows you to adjust that lock time, how long the user has to fire that signal in order to close and lock that digit around what they're holding. That is, of course, adjustable anywhere from, I think, 3 seconds all the way down to as soon as you stop moving. When you are configuring, you still use the iDigits wizard to go through and configure the device. You do have the option for filtering. You want to make sure that in the US, of course, in Canada, it is set to 60 hertz to make sure you can filter out as much of the electrical noise as you can. The configuration wizard is mostly the same right up until the last step where you get to assign the digits to the actual channel itself. We do have some guidelines in the paperwork that tells you it's best, if you're using that first dorsal interosseous to control the index, you make sure you have the channel 1 on your index and channel 1 assigned to the index in the wizard. What this allows you to do is allows you to assign your digits to those particular channels. And the software is smart enough that it won't allow you to assign digits to multiple channels, meaning you can't have your index assigned to both your channel 1 and your channel 2. But you can set up whatever combination of digits you want. If you want that channel 1 to control index and middle, and your channel 2 to control your little and ring, that would be the case. You could set it up to be so. What we see most often is a lot of times we'll end up linking our ring and little finger together because that gives you a little bit of grasp and a little bit easier for most people to control. On the real-time graph, you have the ability to select the channel number on the right-hand side. One of my favorite features about this is all the colors line up. Channel 1 is red, which is the red signal on the graph, which is the red plug on the preamp software itself. So that all lines up as one less thing you have to get a little Sharpie and trace and write on to keep track of. You do have independent adjustment of your gain, your rest threshold, which is the threshold under which the signal is ignored by the processor, but also the release threshold. That release threshold is the level that a user has to surpass in order to get the digit to unlock. And as you adjust that, if you try to bring the release threshold below the rest, it'll automatically lower that threshold. It will not allow you to basically break the system. So every time they're moving, they're unlocking the device. On the graph, you can view everything going on at once, which can be a bit much to parse. So you do have the option, if you are focusing on isolating just a single signal at a time to practice, you can disable the graph view of the individual channels and their thresholds to try to see everything that's going on. Or when you get up to do your training, have them all going at once and see everything all in that kind of bird's eye view. Different features change on the software depending on which control strategy you have enabled. With discrete control, again, we mentioned that the only way to get in and out of those quick grips is using the app. Part of the reason we have done that is that now you don't have to. If a user wants to go into an index point, they can just close those other digits on themselves. They don't have to go into a mode of the hand. They are in control and driving the device. So it's intuitive control of their natural grasp patterns. So you will find in BioSim, gesture control is disabled, the muscle triggers are disabled, and the grip chips are also disabled when discrete control is turned on. The good news is you can always go to a different control strategy and those features will turn back on. That is all adjustable in the software. You don't have to do anything different. In the study, we had our 3 participants. The first user that we had was lost their digits to sepsis. So they were quad, transtibial, and partial hand. There we go. They did have a previous iDigit device. They used dual site control as well as a silicone extension on that thumb to help. You can see in the video, however, they are not using it. What they found for interesting results from this user, one, they did say it was a little bit easier control using the NASA TLX, that test of cognitive burden. There was a decrease in the burden of about 20%. Shaft score went up by almost 60%, which I think is pretty good. Their grip accuracy improved from 76 at the baseline to over 90% at the end of the study. One of the things they did notice in all three cases that they went through is that initially there was a little bit of difficulty when switching from dual site to the discrete control. It took a minute for the users to figure out how to successfully move just that individual digit. And so in the study, the scores would decrease initially, and then over time get back up and then surpass what their scores were using traditional dual site control. In this case, as I did mention before, we did end up linking the ring and little digits. It gave them a little bit more control over index and middle for fine motor, and then gross graphs for the using the other channel. And this, of course, is not something that is set in stone. They can change this in therapy. You as the process can change it, but it is something that would take a clinician access in order to change. You can't do that in the My Island. Second user was another using a prototype 4-site system. This user was a little bit different in that they did have control of their independent digits, but they still tended to use the device for gross graphs. So much so, one of the questions that they were asked is, given that how you use your device, would it be more beneficial, do you think, to switch to traditional dual site control? And their answer was pretty much, why wouldn't I be able to move my individual fingers? Their accuracy with the device was just fine. That's how they operated it. Their shaft score improved by 20% over their original device. Their clothespin relocation speed went up by about 12%. So overall, pretty successful with the device and the discrete controller. Another user of another prototype 4-site system, they were fit with the discrete controller. And the things that we noticed in this particular user, either using tip or gross graphs, similar to the previous patient, good independent digit motion control. The shaft score was already pretty high, but improved by about 4%, 3 points, which is not statistically significant, but it is clinically significant. And then their clothespin relocation test improved by another 16%. So they did have that good individual control of the digits themselves. If we look at how these users went through, how they identified tasks that were both important and difficult, the scores improved by quite a bit. And the first user, if we look at the activities, opening jars, carrying heavy loads, cutting food, what we'd expect, their baseline with the prosthesis was a 1 and improved to a 6. The second user and their task went from about a 5.4 to an 8. The last user, scores didn't improve as much as we really like using the scale. But if we look at the tasks that they were really identifying, golf, racking a handgun, lifting free weights, playing basketball, not things we would typically recommend use of an iDigits for anyway. So it's not really surprising that the score didn't improve a whole lot when using their iDigits device in their goals of choice. From the clinical perspective, there is that psychosocial benefit. The user gets to determine how they're using their individual digits, how they use that hand. Also helps drive acceptance of the prosthesis. On the therapy side, you have the opportunity to proceed from a dual site control to multi-site. All this is done in software. You don't have to keep swapping out hardware or different components. You have that ability to change that in and of itself. And you do have the ability to switch the user between the different control strategies during the sessions, or even to a single site just by day to day as they go throughout and do their training. And then for the first time ever, I'm going to show a video Well, I'm disappointed. I thought we got the all the audio. Hey. Well, rats. Well, you'll see the video more often. I apologize for that. A couple more things that I do want to mention. The discrete controller is only available on the quantum systems. It is there is an upgrade path if you have a user already in an existing quantum system. You don't have to go through and repurchase the whole system, and there's a pathway to go ahead and get that up to the discrete controller. I did see at least one question as we go through. For testing for the discrete control, when testing, can you use the electrodes or the standard auto block? I found in most of these cases, it doesn't really matter what you're using for your myo tester. You can use a MyoBoy, you can use our virtual limb, you can use remotes, you can use compacts. As long as you can find that myocyte and on the graph you can see that discrete control, or discrete, that independent control. You're not getting that crosstalk or that co-contract. They'll be able to use the device when you fit the socket and get that good electrode contact. For the discrete controller itself, when you make the definitive, we are only using the remote electrode style, just the gold domes in the definitive device. And that's what I got. So if you have any questions, you can either toss them in the chat. I'll be here for a few more minutes. If you reach out to your OSTR representative, we do have flyers, we have information. Later on today, we should be sending out the quiz to make sure that you get your CEUs. Please remember to fill out that quiz and send it back. Of course, ABC wants us to